Can I hand over to my colleague Becky? She wants to ask a quick supplementary.
Thanks,
Becky?
Chair. So it's just to come back to the funding, really, and just to try and understand, obviously, with the NHS 10-year plan and devolution moving forward in terms of local government, but also looking at what health devolution might look like. So for integrated care budgets, I'm just interested in terms of how those conversations are going at the moment. And I suppose it relates back to the data paucity, I think. But I think in an ideal world, data would lead funding allocation. So you would be able to identify need, and then you would allocate funding accordingly. And therefore, across the UK, you would have perhaps different funding for different areas, depending on, socioeconomic factors, etc. So I just wondered, at the moment, what level of accuracy in terms of funding allocation do you think there is for maternity services? And I think I can see the answer on your face, but I'm going to ask the question anyway.
I think it's not great.
Okay.
I can tell you there's also an issue about workforce, which we shouldn't really forget. Workforce is really important. Yeah. We were commissioned by the government to do a fantastic work as a Royal College on workforce, obstetric workforce. That has been shelved, not been used at all. I don't know if now, even if it's up to date. But there's also racism within the workforce. So if we don't really know the complexity of each trust and each ICS work, we cannot really relate any particular funding to that particular unit. I work in very interesting two units between Epsom, Surrey, a very affluent area, and then St Helier, where you have kind of big deprived regions. And you can see the difference even when I go to work between the two units on the same day. It's difficult, and I have to work with now 3 ICBs to run my maternal medicine network. So the difficulties are there. I think we need more robust workforce data, and we encourage the government to release those workforce data that we have, but also to have absolutely mandatory training for culturally sensitive kind of approaches, and also the most important thing really that we should not forget that the work that the college recently have shown problems with racism within the workforce, so that if you have a burnt out, unhappy workforce, they will also find it difficult to deliver a good service, in my opinion, and they all go together.
Thank you, Becky. Can we move swiftly on to Dr. Becky Cooper, who will be asking the first questions? Thank you, Becky.
Thank you, Chair. And thank you to the panel for being here this morning. So the opening set of questions for you are around data and data collection. And we've had this as a recurring theme. You're probably going to be unsurprised to hear in our previous sessions on Black maternal health. And in the first evidence session, we had Professor Marion Knight, and she highlighted the fact that we are not collecting maternal morbidity data, and that has some serious implications for what we know and how we can commission services and how the health force is working. We also had the Better Births report, which said that health professionals are working under significant pressure, spend a great deal of their time collecting data, filling in forms, yet the data produced is often of poor quality. The professor in the previous panel also raised the issue of data collecting and said that it was really quite difficult to commission appropriately sized and resourced maternity units based on the data that are available. So in this specific space, looking at maternity care for Black women, Minister, perhaps if I can come to yourself first, do you believe that you have the data you need to effectively hold NHS trusts to account for their performance? And if not, perhaps you could expand on what you think is missing and how you're planning to address that. Thank you.
Thank you. I think there are some limitations on data, but in direct answer to your question, we do need better data. I would certainly agree. I think that what I would draw, and I'm sure the committee is aware of this, but it's just worth mentioning, every maternal death is a tragedy, and we seek to, and this is what we want to improve, we want to avoid the avoidable maternal death. And perhaps I can just say, for me, maternal death isn't about at the time, just about the time of giving birth. I mean, this is something I feel very strongly about. It's anything in relation to giving birth, and that includes after giving birth. When I look at the statistics, and everyone is a person, everyone is a woman who's given birth, who has died for reasons in relation to childbirth, a number taking their own lives. That really brings it home to me. So I do, hope that we can all look at it more broadly. But without saying, can I use these words carefully? Low numbers just make it more challenging. But please bear with me. But make it more challenging to get sort of useful figures that are as accurate as we would like, the numbers of maternal deaths. So there's a bit of a limitation. However, I absolutely want to agree we need better data. Reason, we've got to understand interventions, which ones are working and what isn't working. And so one of the things we're doing already is there's a call for research to tackle inequalities in maternity through the NIHR £50 million fund. And we are exploring a severe maternal morbidity indicator to get data more rapidly and to allow comparisons between trusts, because to the question, I do think that's extremely important. It is the case that trusts are currently incentivised to gather ethnicity information, and certainly 96% of women who gave birth in 2024 had this recorded.
So sorry, Baroness Moran, if
yes.
I could just interject here. So your maternal morbidity indicator through the NIHR research, is that something that is actively being, and I hate the word piloted, but it probably is, in various trusts, and when do you expect the results to be back on that?
Well, perhaps I can bring in Lucy on this, but just to say there are two separate points. We're exploring the severe maternal morbidity indicator, that's one, and separately the NIHR have issued a £50 million challenge. But Lucy can add more depth to it.
And Kate may also be able to come
Yes.
in. But I think your point on data is right, because if we aren't tracking what is going on and what the impact of our interventions are, we won't really see progress or know whether progress is happening. And I think we've heard of 3 different interrelated data points, so mortality, morbidity, so severe complications, but also experience, because they all intersect. So I think we can learn from where we've got good examples, for example, in mortality, of the real-time perinatal mortality, for the babies, and where we can really see that real-time perinatal data enabling trust to act on it, not waiting months or years. And certainly the opportunities to look at how we do that, it is, as we've heard, much harder to do that for maternal mortality because of the small numbers, which is why the focus on the maternal morbidity can be critical in terms of early warning. Mm-hmm. So there are, and Kate may want to talk more about how we track HES data, so hospital episode statistics, and use that to derive a not perfect indicator, and that is lagged to some extent, but it will always be because of how we collect and collate hospital episode statistics data, and then the new work that is being planned, which is linked to the severe maternal morbidity care bundle. So how do we tackle things before they become maternal deaths, which is critical, and I see as an obstetrician every week. So linking through the NIHR application and to the Maternal Inequalities Consortium that NIHR chose to fund, about both developing a care bundle, developing the means to measure it, and then seeing how we improve on the existing HES data composite to actually drive change.
So, sorry, Professor Chappell, just for clarity, so the maternal morbidity indicator, which I know was something that was raised in the Women Equalities Committee report, just to be clear, it's being developed, it's being trialled, there's a timeline.
It's in development at the moment, because obviously the the health issues that lead to women dying
Yeah.
are often preceded things like severe bleeding in pregnancy or blood clots, and those happen at a frequency for women who survive where we can track that in a meaningful way.
Yeah.
And by using that as our proxy indicator, that will enable us to have confidence in the measures that we employ.
Okay, and so just so the committee's clear, if we were looking for data, I don't know, in the next 3 years, in the next 5 years, is there a point where we'd be able to go, okay, we're going to look at this maternal morbidity indicator for trusts across the country, and we'll be able to get the data collected? Is that something that's
Our
built
aim
in?
is
Next
to-
3 years, next 5 years?
It will be less than 3 years.
Less than 3 years. Okay.
Just to say that a composite indicator is not the be-all and end-all. You've got to understand both by condition, but also by what we're talking about here today, by ethnicity, by deprivation. So it's about the nuances of it. So there's the National Maternal and Perinatal Audit, which is run by the Royal College. So we have indicators today of maternal morbidity indicators. It's what you do with the data and how you interpret it and then act on it that really counts. One of the reasons, just to call out Vola's work here, one of the reasons that NIHR funded the Maternity Inequalities Consortium first is because of the Core 20+5.
Yep.
So if we collected an indicator but didn't then understand what was driving the inequalities, we'll have missed the point. It's about both the indicator and the granularity of data.
Absolutely. So thanks, Professor Trouble. That's really point well made. So just before I hand back to the chair, just to probably follow on with what you're saying, in March 2025, as I'm sure you know, the former NHS England issued a statement that they've been working with midwives, obstetricians, nurses and other clinicians to create the maternity record standard relating to direct patient care, describing optimal data structure and format of maternity record. Could you please give us an update on that digital maternity record standards and where you are with that process?
Might be helpful if Kate.
Is that Kate?
Answer,
Brilliant,
yes.
thank you.
So this was about unifying how we collect data, because one of the things that you've pointed out is the quality of data is so important, and the record standard was about making sure that everybody measured the same thing in the same way. So just one example is the weight of a baby. You can measure it in pounds, ounces, grams, kilograms. It gets entered in the wrong way, you end up spending a lot of time cleaning data. So going into that level of technical clarity was a really important point. Particularly as in a complex pregnancy, you might have 1,900 points of data collection for a single woman. So it's a massive undertaking getting the right data with the right quality. Bola, did you want to come in?
Thank you. Just 3 things. So first of all, NHS England set out 5 strategic actions for addressing health inequalities. And one of those is to ensure that data sets are timely and complete, especially ethnicity coding. And in response to that, we've developed an ethnicity recording improvement plan, which was literally just approved through our Quality Performance Committee yesterday, and is going through the publication process. We've also worked to develop a set of metrics and indicators to track key metrics within maternity, for example, stillbirths, neonatal death rates. And again, we're working to incorporate that into NHS England's performance and assurance framework in the coming period.
Great, that's very helpful. Thank you so much. Pass back to
Can
the
I
chair.
just
sorry,
come
go on.
back, Can I just come back to the role of women in this?
Yeah.
That we know that we need to actively involve women in data, both as a general concept in terms of public trust in data, but also in their experience. And so the work that's being done to co-create that experience is important. So sometimes it's easy to say, can you produce it in 3 months? Well, I could, but it wouldn't involve meaningful co-production with women. So to get back to understanding how we triangulate these different types of data and what they mean, women can have technically good care, but if they have a poor experience with it, we haven't delivered what we're setting out to.
Yeah, excellent point, Professor Trouble, and thank you. And I could talk to you for hours about quantitative and qualitative data, but I will hand back
We'd
to the
be
chair.
happy to.
Please.
Sorry, so just on the basis of funding, and I appreciate that NHS funding is incredibly complicated, but has there been a conversation whereby all maternity services are going to need a certain level of funding to provide basic maternity services, regardless of their indices of deprivation, etc.? So is there a conversation whereby you think, okay, here's the baseline that all ICB must all ICBs must fund to this level, and then the data issue I understand is quite difficult, but if you had decent data, you could therefore say to the ICBs, based on the data you have, then you can allocate your additional funding for those maternity services based on, you know, the data that you have. Are those sort of conversations happening in the NHS at all?
Yes, they do, and
Okay.
I think it's probably also worth referring to, you know, the upcoming 10-year plan, and committee members won't have to wait too long. Don't often hear a minister say that about something that's to be published, but I would emphasise there is significant and ongoing investment, and we have instructed the NHS to improve preventative healthcare as well as maternity as a priority in the planning guidance when we come on to the discussion. But colleagues who would like to, I think it's probably worth adding some
We're
experience
getting
here.
confused here.
Yes.
Joe, you have got a couple more questions, haven't you?
Just on the planning,
Sure.
on the planning guidance, although that funding was quite an interesting discussion. So the latest planning guidance is less detailed on lots of things, but in this case on maternity than in previous years. How will you ensure that ICBs still prioritise maternity care, and what tools are available to hold them to account? So it's a similar principle, not with funding, but with prioritising around maternity.
Well, there are. Well, number one is, as I said earlier, and as you have identified, it is within the planning guidance. That is helpful. I would also say, and we may come on to this later, Chair, I don't know, but I'll mention it now. Of course, there are expectations of the government, as clearly set out in the manifesto and also in the missions, in terms of maternity, but also improving healthy life expectancy, just to name one other. And later this year, we will be setting out what our new ambitions look like for maternity and how they'll deliver improvements. So more generally, I'm going to, if I may, Chair, sorry, is it okay, Chair, if I invite colleagues to add some detail?
Can we be succinct? So
Yes, of course.
Who can answer this point?
Yes.
So just
without-
one specific is we have to ask how we look at maternity differently, starting from pre-pregnancy. And a huge shift in the complexities that I've seen over my lifetime as an obstetrician means that we can't just start at, after booking at 12 weeks. It's just not going to work for tackling the inequalities that this committee's heard about. So that wider piece about pregnancy being an event in a woman's life course and the focus on the move to prevention, I think we've got to ask the ICBs to see that in the round rather than just maternity services.